This is Unit 1D, Social and Environmental Influences on Children. Many major causes of mortality or morbidity in children are closely linked to social influences. And then obviously the environment impacts health, especially on children. So when we talk about injuries, poisoning treatment, first and foremost, poisonings are the second leading cause of unintentional home injury deaths. And the goal of treatment overall for all poisonings is to prevent further absorption and then to reverse the effects. So when a child who has been poisoned comes in, first and foremost, you need to assess the child. You need to do your ABCs and stabilize the airway if needed. You need to remove the toxin if possible, so do gastric decontamination and dilute with milk or water, depending on if they're acidotic or alkalotic substances. You're going to do gastric lavage or bowel lavage. You may have an absorbent agent, which is activated charcoal. You may have a cathartic agent. They really don't recommend inducing emesis anymore, and they don't even recommend that you have it in your home anymore. And if you're lucky, there may be an antidote. Table 1711 on pages 396 to 397 go over all the toxic agents that we talk about and what you can do for them. So it's a good resource if you like to look at that visual. Tylenol poisonings are the most common poisonings in pediatrics. It does cause liver damage, can cause liver failure, and it starts to begin at 150 milligrams per kilogram. Children younger than 6 years old are more resistant to developing the hepatotoxicity. The first stage, which is in the first 24 hours, they're gonna experience malaise, nausea and vomiting, sweating, pallor, and weakness. The second stage, which is 1 to 3 days, is the latent period. They're going to have an increase in liver enzymes and bilirubin. They're going to have right upper quadrant pain and a prolonged prothrombin time. The third stage, which is a week, includes jaundice, liver necrosis, and possible death from liver failure. So the first thing that you're going to do, I forgot to say this, but the first thing that you're going to do when somebody comes in with Tylenol poisoning is you're going to draw a Tylenol level. So you're going to draw that Tylenol level if they're breathing, like I said, if they're stable, draw the Tylenol level, and then you will call poison control and they will direct you on what to do. So the treatment for Tylenol poisoning is activated charcoal. I don't know if you've ever seen it or given it. It is not a very fun experience. It is black and thick, and I cannot imagine swallowing it. What we used to do in the ER was mix it with grape juice or chocolate milk, because then the child doesn't realize that there's charcoal in it. But again, in order to thin it out, you've got to mix it with a lot of liquid, so it's a delicate balance. And then there is the antidote, which is Mucomist, which prevents the absorption of the Tylenol and protects the liver. It does smell like rotten eggs, and you give it orally with juice or cola, or you can give it via an NG tube. You can also give the activated charcoal via an NG tube. Salicylate poisoning, which is aspirin. Severe toxicity is 200 to 280 milligrams per kilogram. Peak absorption occurs within 2 hours of ingestion. So again, you're going to draw an aspirin level as soon as they get in the door and go from there. They may have bleeding, tinnitus, increased temperature, hyperventilation, nausea, vomiting, metabolic acidosis, hypokalemia, and coma. Treatment for this is activated charcoal as well. We're going to give some sodium bicarb for that acidosis, vitamin K for bleeding, and you're going to monitor potassium and check their hydration status, make sure they're hydrated. Lead poisoning, which is plumism, used to be a lot bigger problem than it is now, but signs and symptoms include irritability, nausea, vomiting, and pain, diarrhea or constipation, and it can lead to lead encephalopathy, so brain swelling. You're going to have some behavioral changes there, learning difficulties, hyperactivity, increased intracranial pressure. You're going to have seizures, coma, and it can even lead to death if the level is greater than 100 micrograms. Causes of lead poisoning would be pica. Children are eating things that are not food. Lead-based paint used to be a huge issue for lead poisoning. I know if you buy a house or rent an apartment or anything that had that was built, I think, before like 1970, then they are required by law to notify you that there may be lead-based paint somewhere on the walls, and you have to sign paperwork saying that you have been educated on this. Children used to eat lead-based paint. This has obviously decreased with the type of paint we have now. There's also lead-based gasoline, lead-glazed pottery, and water that is flowed from old lead pipes, which is what happened in Flint, Michigan. So as those pipes age, the lead kind of sloughs off. So it would be important to know what kind of pipes are in your city and in your house and your apartment building. You're going to have major toxic effects. You're going to have bone marrow, and it's going to cause anemia. Your nervous system, we talked about increased ICP, seizures, coma. It's going to affect your kidneys. So a diet high in fat and decreased in iron and calcium will increase the level of the lead absorption. So you want to do the opposite of that, obviously. You want to have a diet that's going to decrease the amount of lead absorption. So you need a diet that is low in fat, high in iron, calcium, phosphorus, and vitamin D. And you want to make sure those children are eating meals at a regular interval because lead is more absorbed on an empty stomach. Chelation therapy binds with the metal, and it is excreted by the bowel and kidneys. These are the meds that you can give, so either IM, IV, or PO. And then be sure that the child is discharged to a lead-free environment. If they have pica and are admitted for lead poisoning and they go back to the house with the paint that has lead in it, they're probably going to continue to have lead poisoning and come back to the hospital. Obviously, in Flint, Michigan, basically they can't drink the water. They need to use bottled water for everything. So that is a little trickier. And if you have, like lead pipes in your house, that will take time to address. Iron poisoning, so either they ingest iron or vitamins with iron, and iron tablets resemble candy, and so the kids think they're candy and eat a lot of them. Toxic dose is 60 milligrams per kilogram or larger. It is corrosive on the GI mucosa and it can leave deposits in the liver. The first stage is in 1 to 4 hours. You're going to have bloody stools, vomiting, abdominal pains. Second stage is 8 to 12 hours. The symptoms actually subside, and so they're asymptomatic for 12 to 36 hours. So, for example, if they have iron poisoning and they've got some vomiting and abdominal pain that only lasts for 4 hours, you might think they have a GI bug if you don't know that they have eaten a bunch of iron tablets. And then you think, oh, well, they got over that GI bug pretty quickly. But in fact, they didn't. The third stage, they're going to have a fever. They're going to have metabolic acidosis, shock, seizures, and coma. So hopefully you will realize that they have ingested iron before it gets to this third stage. With this, you're going to have gastric lavage, chelation therapy with deferoxamine. Just be aware that this drug does create their urine to be red, pink, or orange in color, so don't be freaked out, and tell definitely the parents and the children not to be freaked out as well. You're going to give IV fluids and sodium bicarb. Corrosives, sources are batteries, household cleaners, bleach, which is really important. We talked about earlier about baby-proofing your home, making sure that they can't get a hold of those cleaning agents. Manifestations are vomiting, drooling, swallowing difficulty, burning or pain in the mouth, throat, or stomach, and they may actually have edema of their lips, tongue, or pharynx. So you may need to intubate them, which could be difficult if their tongue and lips are extremely swollen. You do not want to induce vomiting because it can actually be corrosive coming back up, and then it can also cause the lips and the tongue to swell even more, which would obviously be a bad thing. And you can dilute the toxin with water. Some more sources are gasoline, furniture polish, lighter fluid, paint thinner. Manifestations of these are gagging, coughing, nausea, vomiting, altered mental status. Respiratory signs and symptoms include tachypnea, cyanosis, retractions. Again, do not induce vomiting. You may have to do gastric lavage for highly toxic materials and respiratory supportive care. So that's it for all the poisonings, but obviously poisonings can be very dangerous and very severe, and education is a key to preventing these. So now we're going to talk about child abuse, not a very pleasant topic, but I will tell you that I was not prepared in any shape or form for the amount of child abuse that I would see in my nursing career, and it really weighed heavily on me when I worked in the pediatric ER, and it can definitely lead to cynicism in nurses as well as nurse burnout, and it is a very serious issue that I don't think the public or even a lot of healthcare providers fully grasp just how serious and how common it is. It certainly knows no race or ethnicity or class or anything like that. It happens across the board. There are some risk factors: poverty, violence in the family, prematurity or a low birth weight. You know, if you have a premature child, they are going to require probably more home care than the parents were anticipating, and so that can cause some anger towards the child from the parents. If you have an unrelated male primary caretaker, if you have parents with a history of abuse as children, tends to be very cyclical. If the children are less than 3 years of age, they cannot tell people what's going on at home. They may not be able to voice that, and so it is a risk factor. Physically disabled children, ADHD and MR as well. They, again, don't have, quite the defense that children without these illnesses would have, and they may not even be able to verbalize what's happening. Substance abuse of the parents and social isolation of the parents can all lead to, or all risk factors for child abuse. Again, multiple family stressors. If there's financial troubles in the home, that can lead to child abuse. If they are a single parent or teenage parents, can also lead to child abuse. And being a female is also a risk factor. Females are more likely than males to experience abuse, not only in their lifetime but in their childhood. So risk factors: inadequate communication among family members, a lack of parental knowledge of normal growth and development. If the parents don't know, for example, that your child may not be potty trained until 3 years old, they may get extremely frustrated and take it out on the child. So again, education is extremely important. These are the different types of abuse, and we're going to dig farther into them now. Physical abuse is a deliberate maltreatment that inflicts pain or injury on the child. Typically, you're going to have unexplained bruises, scars, or welts in various stages of healing, because typically child abuse is something that occurs, over a long period of time, and so some of the bruises might start healing, and then the next night the parent abuses the child again, and so now they're going to have new fresh bruises. So that is always a red flag to nurses during your assessment. They have bruises on the mouth, the lips, or the eyes. They have an unexplained swollen extremity. They have bite marks. That's a tough one because toddlers sometimes will bite each other, but always ask the parents where it came from. And then bruises in the shape of recognizable objects, such as a belt buckle or something like that. I will tell you, it is so important that you look and do a thorough skin assessment on every child that you have. It was always a pet peeve of mine in the ER if the nurses did not get their children into gowns, because if you don't get them into a gown, you cannot see and adequately assess their skin. And I can't tell you the amount of times that the child came in for something totally unrelated. We get them into a gown and see bruises all over their body, and then they now, are a totally different ballgame and are getting admitted to the hospital. So the skin assessment is so important, and getting them fully undressed is extremely important. Again, continued physical abuse, injuries in locations that the child cannot reach, hot water, scalding marks. Sometimes parents will use that as a form of punishment. They have limited range of motion or complain of tenderness if they have a skeletal injury. Behavioral indicators of the parents. Are they passive? Are they aggressive? And if they're aggressive, do they become extremely hostile very quickly? Psychological abuse is an aim to frighten or control the child. It's an act of omission or commission deemed psychologically damaging, and it's usually in the presence of a hostile behavior. You're going to have the absence of positive parenting behavior. Caregivers may be aware or unaware of the hurt or pain they are causing. If they are, a teenage parent and just are not developmentally or cognitively there, they may not even be aware of what they're actually doing to their child. And it's typically, like I've talked about before, cyclical, and they're repeating a pattern from their parents. Evidence or signs and symptoms that psychological abuse is happening in the home: poor self-esteem, poor academic performance, especially if they are a straight A student and then all of a sudden they're making C's and D's. Something is going on, and either the teacher or the nurse needs to get to the bottom of it. If they have acting out behaviors, again, if they are usually a calm and well-behaved child and then all of a sudden they start acting out, you really want to ask why. They don't have friends or a peer group, and if they suffer from depression or mutilating behaviors, and if they don't trust adults, which a lot of teenagers don't trust adults, but again, you want to just kind of delve more into it, and that's where your interview skills and therapeutic communication comes into play. Sexual abuse. So approximately 10% of school children report that they have been sexually abused, which is such a high number and so sad to me. The perpetrator is usually known to the child and to the family. Forms of sexual abuse, I'm going to define a couple that you may not know. Incest is obviously between close family members. You've got sexual assault, exploitation. Exhibitionism is obtaining sexual pleasure by exposing one's genitals to a stranger. So, someone may come over to the house for the first time and they go into the child's room and they just pull their pants down, and that's what gets them off. Unfortunately. So, these are signs and symptoms of sexual abuse. The child may be inappropriately friendly with unknown adults, like may sit on their lap or touch them inappropriately because they've experienced it and they don't know that it is inappropriate. They're going to have inappropriate coping behaviors. They're going to have mood regulation problems. They're going to be up and down and all over the place. They may have cognitive problems, sexual problems, and then a lot of times with sexual abuse, there is not always an apparent injury. So like we just talked about exhibitionism, it doesn't even involve the perpetrator touching the child, but obviously it is a form of sexual abuse. And then a lot of times these children have decreased self-esteem. Shaken baby syndrome, this is very common. Unfortunately, I saw a lot of it in the pediatric ER. I think all of you that are parents and have experienced raising a child, and this is from working in the ER and from talking to doctors that have had children, and this should be educated to all parents before they even have children, there is going to be a time when you are raising that child that you feel like you are at your breaking point and you are so frustrated and you have a lack of sleep and you have done everything that you know possible to get that baby to stop crying and they don't. And when you reach that point, honestly, you need to put the baby down in the crib in a safe environment and just walk away. You can even walk outside if you need to. the baby's changed and in a safe environment and has been fed, that baby is going to be fine for 5 or 10 minutes while you collect yourself and calm yourself down. I wish that more parents had that knowledge and had that coping ability. But it leads to whiplash, induced intracranial and retinal bleeding. A lot of times on autopsies, they will see retinal hemorrhages, and that is how they know that it was abuse that killed the infant. It's most commonly seen in infants, but it can also be seen in other age groups. Typically, the children present with failure to thrive or seizures, apnea, respiratory issues, are in a coma, or vomiting that leads to drowsiness and lethargy. I will tell you probably the most common symptoms that I saw would be the child would have a seizure and they would be brought in for that, or the child would just not be eating and it would have been several days and the parents would be concerned, or they're so drowsy that they are not arousable because they've had so much brain damage. Munchausen syndrome by proxy, you may not have heard of. It really pretty much only exists in pediatrics. It is extremely hard to diagnose. It's defined by made-up signs and symptoms of a health condition in a child. The parents make up these signs and symptoms, and it's usually the mom that makes them up, and it happens most of the time in children less than 6 years old because they cannot verbalize, what's going on. They can be brought in for bleeding, seizures that never happened, CNS depression, apnea, diarrhea, vomiting, never happened, fever, rash. And it is a psych disorder of the mother or the primary caregiver. And so as soon as you get that mother or primary caregiver the help that they need, all of a sudden the health issues disappear from the child. So prevention of child abuse is a huge role of the nurse in a way that they can participate in preventing these horrible things from happening to children. Parenting classes are really important, especially before the baby's born. You can teach respect for genders. You can establish individual family role expectations. You can educate them on normal growth and development and talk about appropriate communication methods. And you also can teach children the difference between good and bad touch. Legal aspects of abuse. We are mandated by law to report suspected abuse to police or CPS. This is an important mandate that I would take very seriously. And I will tell you, I made many more reports than I ever thought I would. I will also tell you that it is not up to you to figure out who's doing it or whether or not what you see is accurate or not. What you need to report is what you see and what you're concerned about. And then it is actually up to CPS to conduct that investigation and to dive farther into what's going on in that child's life. You are given immunity against prosecution. I can tell you in the hospital, a lot of times you will report what's going on to the social worker, and then they will be the ones who are responsible for filing the report for CPS. However, I did have an instance or two where the social worker did not feel like it warranted a CPS report, so I made the CPS report myself. And then certainly if you're in the community, you're going to be the ones calling CPS yourself. Document all client and caregiver interactions. This is extremely important. So questions to ask yourself about the injuries of a child. Does the injury make sense in terms of the child's age? Does the parent's explanation compatible with the injury, or is the parent's explanation compatible with the injury? Does their story change? Because that is a huge red flag. If they tell the nurse one story and then they tell the resident another story and then they tell the attending another story and then the social worker another story, that's again why documentation is so important. If their stories don't match up, that's a huge red flag. And do they have unexplainable bruises, burns, and fractures or dislocations? So like I said, does the injury make sense in terms of the child's age? We would get all the time that, again, this is why knowing developmentally what happens is so important for pediatrics. It all is based on that. But a lot of times we would get, oh, the child rolled off of the sofa and the child's only 3 months old, and that developmentally the child cannot roll from the back to the front, and they broke their leg from rolling off the sofa. Well, again, that's just not possible based on their age. Or the child fell down the stairs and the child isn't old enough to crawl yet. So just ask yourself these questions. Documentation is very important. Again, we've talked about that. And then sorry that this was such a long lecture and not a very uplifting one, but it is extremely important. And like I said, it has affected my nursing career more than I ever thought it would. And I hope that it doesn't affect yours as much. I hope that we figure out a way to really address these issues. But know that as an individual, you need to figure out ways that you can cope with these realities of the world and of life, and you need to find out ways that you can decompress. So I am here not only if you need questions, but if you ever need to talk about some of the difficult things you see as a nursing student and as a nurse.